Good morning, everyone. On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meet. In Rheumatology Clinical Pulse series, today's topic is interstitial lung disease in rheumatoid arthritis and systemic sclerosis. We have two excellent speakers, Professor Rohini Handa and Dr. Sapan Pandya. Professor Rohini Handa will speak on rheumatoid ILD management issues. And after Dr. Handa's talk, Dr. Sapan will speak on scleroderma ILD management issues. And after these two talks, we will discuss common management issues in ILD, both in rheumatoid arthritis and scleroderma. And I invite questions from all the audience for this session. Professor Rohini Handa is currently working as senior consultant rheumatologist at Apollo Hospital, New Delhi, India. Professor Handa's contribution to rheumatology have been recognized by several awards and citations by the Indian Council of Medical Research, Aman Sen Oration Award, and Shakuntala Amirchand Prizes. Then IRA Oration, the Association of Physicians of India, Netaji Oration, Searle Oration, J.C. Patel and B.C. Mehta Prize, Pawan Kumar Oration, Dr. J.M. Berry Award, and the Indian Academy of Clinical Medicine Dr. G.B. Jain Oration and Dr. Sukumar Mukherjee Honor Lecture, amongst others. Professor Handa was conferred the Distinguished Academician Award by the Apollo Hospital in 2018. In an illustrious career spanning 4 decades, Professor Handa has held several leadership positions, distinguished clinical tutor, Apollo Hospitals Educational and Research Foundation 2019 to 2020, honorary consultant in rheumatology to the Armed Force Medical Services 2017 to 2020, Dean of the Indian College of Physicians 2017-2018, President of Asia Pacific League of Association for Rheumatology 2010 to 2012, Chair of International League of Association for Rheumatology 2012, President of the Indian Rheumatology Association 2009 to 2011, and President of Delhi Rheumatology Association 2010 to 2012. Professor Handa has serves on the editorial board of respected medical journals, including Rheumatology Oxford, Current Rheumatology Reports, Best Practice in Research Clinical Rheumatology, Indian Journal of Rheumatology, African Journal of Rheumatology, Indonesian Journal of Rheumatology, and Journal of Association of Physicians of India. He is the author of the immensely popular book, Clinical Rheumatology. With this background, I invite Professor Handa to deliver his talk on RA-ILD. Professor Handa, sir.
Thank you very much, Banwari, for this rather generous introduction. And let me begin by sharing my screen. Are my slides visible?
Yes, sir.
Friends and colleagues, Dr. Sharma, Dr. Sapan Pandya, at the outset, I would like to thank the Niramaya Foundation for inviting me to speak at this digital CME. Sarve Santu Niramaya. I think my Sanskrit is heavily laced with Punjabi accent, but may all be healthy. And that's what I understand is the meaning of this saying. And this foundation is very aptly named Niramaya Arthritis and Immunology Foundation. And I would like to thank Banwari for inviting me. And my brief this morning is to talk about ILD in rheumatoid arthritis. And I have tweaked the title a little. And from management issues, I've tweaked it to practical issues. Now, rheumatoid arthritis has the distinction of being the commonest inflammatory polyarthritis that one encounters in clinical practice. It is by no means the commonest joint disease that you see in clinical practice. That distinction belongs to osteoarthritis. But when you talk about inflammatory polyarticular diseases, this tops the list. And let me start with the story of this lady. This was a young woman, rheumatoid arthritis, 5 years duration, well controlled, and she presented with shortness of breath. This is a chest X-ray, and on investigations, the PFT revealed reduction in DLCO. HRCT confirmed interstitial lung disease. So this was rheumatoid arthritis with interstitial lung disease, and this underscores the fact that there is more to rheumatoid arthritis than joint pains. It's a systemic disorder. Yes, indeed, pains bring the patient to the doctor. However, other organs too can be affected, and interstitial lung disease is an important extra-articular complication of rheumatoid arthritis. And I'll show you some other examples. Dry eyes, episcleritis, scleral involvement, rheumatoid vasculitis, and you can notice this wrist drop, atlantoaxial dislocation, digital gangrene. So rheumatoid arthritis is indeed a systemic disease. And while talking of extra-articular complications, let's not forget accelerated atherosclerosis and, of course, compromised bone health. And as physicians, as rheumatologists, we need to be aware of different dimensions of this joint disease. Let me then shift tracks to another patient. This was a patient who presented with fever, arthralgias, weight loss, and this was the chest X-ray, and you can notice infiltrates on the chest X-ray. Also had rheumatoid factor positivity. The sputum for AFP was positive, and this was pulmonary tuberculosis, sputum positive, and this brings to the forefront two important points. First, infiltrate on a chest X-ray. The most common cause is infection. Alveolar hemorrhage, vasculitis, exotic conditions certainly figure on the list, but remember the most common cause in the community is infection. The second important point that this case underscores is rheumatoid factor positivity does not imply rheumatoid arthritis. Several conditions can trigger RF positivity, and this lady had tuberculosis with rheumatoid factor positivity. Now, with these two case vignettes, let's plunge into the topic proper, the lung in rheumatoid arthritis, and let me list the types of lung involvement that you can get in rheumatoid. Diffuse parenchymal lung disease, in which you have rheumatoid ILD, which is going to be the focus of discussion today. Then you can have rheumatoid nodules, and I'll show you a picture. And then you have the well-known Kaplan syndrome, which was described by Tony Kaplan in Cardiff, which is pneumoconiosis in a setting of rheumatoid arthritis. And this was in Welsh coal miners. But the one that practically concerns is rheumatoid ILD. But there is more to rheumatoid lung disease than ILD. You can have airway involvement. You can have bronchiectasis, pulmonary hypertension. Far more important in scleroderma, and Sapan Pandya is going to talk about it, but can also happen in rheumatoid arthritis, pleural involvement. And when we talk of pleural involvement, well, lupus tops the list in terms of commonality when we look at connective tissue diseases causing pleural effusion. But let's not forget rheumatoid arthritis, and occasionally pleural effusion may be the first presentation of rheumatoid arthritis. As I have learned to my cost, a male patient presenting with pleural effusion, no joint pains at all, investigations ordered by the physician, rheumatoid factor positive, anti-CCP positive, pleural biopsy unrewarding, eventually responded to disease-modifying anti-rheumatic drugs and corticosteroids, and would not accept a diagnosis of rheumatoid arthritis, stopped treatment, relapsed, and he is still with me. It's several years now. So you can have pleural effusion. And then let's not forget that these people are susceptible to infections, and there could be drug-related issues pertaining to the lung. This is a lady who's had rheumatoid for 30 years, 3 sisters, all having rheumatoid arthritis, and she has these multiple nodules which have been with her for decades. These are 2 patients with interstitial lung disease, and the question that emerges is it a theoretical concern or clinical reality? Why has Banwari opted to have a discussion on this topic? Now, if you look at the frequency of ILD in rheumatoid arthritis, case finding estimates, huge variation. You could have it from 8 to 80%, but clinically significant ILD ballpark figure is about 5%, ranges from 2 to 8%, but 5% people are going to have clinically significant ILD in rheumatoid arthritis. What might be the risk factors for ILD in these patients? Severe rheumatoid arthritis, high titers of rheumatoid factor and anti-CCP, male gender, cigarette smoking, older age, these are well known. Disease duration, the literature is variable. Some studies do point out towards disease duration, but others do not endorse it. And then you have a genetic variation, a mucin 5B promoter variant, and SNPs in this gene could be responsible or predisposing to interstitial fibrosis and have also been implicated in RA-ILD. But male gender and of the reversible factors, cigarette smoking. So these patients should be encouraged to give up smoking. Now, this seminar focuses on management issues. And I think from a teaching learning perspective, there are only 4 issues for a clinician. When should he or she suspect ILD in a patient with rheumatoid arthritis? How best to confirm this? Who should be offered treatment? And what should be the treatment for these patients? And these are the 4 issues that I am going to discuss one by one. When should a clinician suspect ILD in a patient with rheumatoid arthritis? And this is shortness of breath, non-productive cough, usually insidious in onset. Acute presentations are uncommon but not unknown. Sometimes patients may have fever and chest pain, and there is a caveat here that mobility restriction means that these patients do not walk enough, exert enough. So this limitation of dyspnea on activity may be under-recognized or may go unrecognized for long periods of time. So shortness of breath, cough, insidious in onset, you need to suspect interstitial lung disease. How can we confirm it? The modality of choice is a high-resolution CT. that you can do in these patients. And then you have supportive investigations, which include PFTs, and you need a full PFT, which includes a gas transfer, and sometimes you need a lung biopsy. Clinical examination and chest X-ray are insensitive methods for detection of ILD. So if you are relying only upon the presence of basal crepitations, clubbing, those may come up late, may not be so easily apparent, and chest X-ray also is an imprecise method for picking up ILD. We now have well-described patterns on the CT. Most radiologists now make an attempt to describe these patterns. The commonest pattern that you get on HRCT is the UIP pattern. Unlike other connective tissue diseases where NSIP pattern, the non-specific interstitial pneumonia, is more common, UIP seen in about 2/3 of the patients, NSIP in about 25% patients, and then you have less recognizable varieties, cryptogenic organizing pneumonia, and you can have a mixture of overlap syndromes. And in UIP, you get fibrosis and honeycombing, you may get traction bronchiectasis, and in NSIP, you get ground glassing, and you can get mixed picture also. Lung biopsy with the advent of high-resolution CT is seldom, if ever, required. You need it in atypical situations where the patient is not responding to treatment or where, for some reasons, infection or malignancy is one of the differentials. And in patients who need a pathological diagnosis, TBLB is unrewarding. The amount of tissue that you get with a transbronchial lung biopsy is insufficient. So actually you are looking at a VATS procedure, which is less invasive than an open thoracotomy, but lung biopsy in clinical practice is required only occasionally. And this is the patterns that you get. UIP shows reticulonodular shadows, honeycombing, and ground glassing is seen in NSIP. In NSIP, you get homogeneous cell infiltrates, whereas in UIP on a biopsy, you get what has been described as temporal heterogeneity. On one side, you have fibrosis. On other side, you could have a normal-looking lung tissue, and you have these variable lesions, which is being termed as temporal heterogeneity. Some practical issues. How do you stage the extent? And this is borrowed from scleroderma. Perhaps Sapan will talk about it. On the CT, if you have less than 20% involvement, that's mild disease. More than 20% involvement is extensive disease. But this is mainly in the context of systemic sclerosis and has been borrowed from there. And indeterminate is intermediate, and then you look at a forced vital capacity more than 70%, you put it as a mild disease, and where there is a decline in the forced vital capacity, you call it disease with a higher risk of progression. Then what about interpretation of the bowel fluid? Most of us are familiar with joint fluids, but when you look at bowel fluid, and this is for the postgraduates who might be attending, the normal bowel fluid has alveolar macrophages, lymphocytes 5 to 15, neutrophils are just about 1 to 3%, and bronchoscopic lavage, bronchoalveolar lavage is required when you are seriously contemplating infection, and things like PCP can be picked up, or fungal infections can be picked up. And this is the normal bowel fluid. When you have a setting like this in a patient of rheumatoid arthritis, ILD is not the only consideration. You need to be alive to the possibility of drug-induced lung disease. Don't forget infections, and you can have infections concomitantly with ILD. ILD doesn't exempt you from infections. Heart failure could be responsible for some of these symptoms. gastroesophageal reflux, malignancy, all of these need to be kept in mind. While at this, let me spend some more time on drug-related lung disease in the context of rheumatoid arthritis. And this is a big listing, almost all drugs, anti-TNFs, Ritux, tocilizumab, sulfasalazine, methotrexate, and you have a whole lot of conditions. But the one that concerns you and me as clinicians is, what about the synthetic DMARDs, in particular methotrexate? And this is a pernicious belief prevalent not only amongst doctors, but also amongst even pulmonologists, that methotrexate needs to be stopped in presence of ILD. And I want to debunk this. Methotrexate does not cause ILD. It is the disease that causes ILD. It's not the drug that causes ILD. And should your patient with rheumatoid arthritis develop ILD, you need not discontinue methotrexate as a knee-jerk reaction. There is abundant literature now available, multiple publications which say that methotrexate might indeed be protective. And this is one of the recent studies which mentions that this was a case-controlled study, that methotrexate use is not associated, and there are several other publications. So the thinking now in most rheumatology circles, or almost all rheumatology circles, is that we need to discuss with our pulmonology colleagues and not deny these patients methotrexate. Methotrexate can, however, cause hypersensitivity pneumonitis. It can rarely cause that. And how do you recognize that? It's usually subacute in presentation. Within 3 to 4 months of the initiation of methotrexate, patients may come down with fever, cough, widespread crepitations. X-rays and CTs may show eosinophilias, show infiltrates, and the presence of eosinophilia is seen in nearly 40% of these patients. So usually if you have a patient where you have initiated methotrexate, comes within a few months with worsening shortness of breath, subacute onset, rarely explosive onset, you should be aware of methotrexate pneumonitis. It's uncommon but not unknown, and you need to stop methotrexate and perhaps not reinstitute it again. But ILD, somebody who's had rheumatoid for 5 years has been on methotrexate for most of these years, that is uncommon, and you need to blame the disease rather than the drug. We come back to our basic template, the 4 questions that we are addressing. When to suspect, how to confirm, and I've talked about HRCT, the limited role of histopathology, bowel fluids. I've emphatically mentioned that methotrexate does not cause ILD. The next question is, how do you treat rheumatoid ILD? And the first and foremost is the recognition of this truth that not all rheumatoid arthritis ILDs need treatment. And I showed you widely varying figures that if you go actively searching for it, 3/4 of your patients may have some mild ILD. How do you identify patients who need treatment? It's an amalgam of clinical factors, PFT abnormalities, and radiologic changes. So young patients who are symptomatic, PFTs which show a progressive decline, the forced vital capacity is less than 70%, the LCO less than 70% of the predicted DLCO, an amenable histopathological type, NSIP, or a HRCT with predominant ground glass opacities, and you amalgamate this and take a decision on treating. The presence of mild crepitations at the base, few reticular shadows on an X-ray or on HRCT with plumb normal PFTs, you actually need to wait and watch rather than institute treatment. Just as it is important to know who to treat, it's equally important to know who not to treat. So asymptomatic patients with a few radiological abnormalities, and this is where we need a cross-disciplinary perspective. We get a lot of consults from pulmonologists, ILD. अपने डॉक्टर साहब से पूछिए कि फॉलिट्रैक्स मीथोट्रेक्सेट बंद करनी है कि नहीं. So this is the setting that we need to discuss with colleagues, that these patients should not be deprived of the benefit of a valuable drug. If there is some radiological shadows appearing and the symptoms are paucisymptomatic patients or minimal, patients who have stable PFTs or HRCT, then patients with extensive honeycombing, a UIP pattern, and older patients where the RA-ILD is unlikely to be responsive to treatment. At times, it's better to wait and watch. And then, of course, this is a dynamic evaluation, not etched on a tablet of a stone. You need to, but in general, these are the situations where you should be more circumspect rather than institute treatment straight away. Then there are some caveats that PFT abnormalities are not uncommon in rheumatoid arthritis. So one odd parameter outlier out of range, do not rush to institute treatment. Do not base your treatment decision based upon these. And of course, articular treatment disease needs to be treated on its own merit. So if you have a patient, you could have all permutation combination, bad joints, reasonable lungs, good joints, terrible lungs, or you could have both being quiescent or both being active, and you need to treat the arthritis independently. Which brings us to the fourth practical point for the clinician. We've identified ILD. We have taken a decision that this patient needs treatment, progressive disease, is symptomatic, has a decline in physiological parameters, has radiological imaging which suggests that needs treatment. How do we go about it? General measures are important. Advise them to give up smoking. If there is anemia, correct anemia, vaccinate them, and of course pulmonary rehab, and we as rheumatologists know about joint rehab, but then pulmonary rehab is equally important in these patients. This is the therapeutic armamentarium that we have available for rheumatoid ILD. Corticosteroids, mycophenolate mofetil, and azathioprine and cyclophosphamide. And over years, there has been a growing disenchantment with cyclophosphamide. Not that it is not effective, but you have safer drugs which are available. There are increasing concerns about gonadal toxicity in these patients and long-term risk of malignancy, which is why the use of cyclophosphamide is reserved now for recalcitrant, refractory, rapidly progressive patients and not used upfront. And when we talk about biologicals, then of course we have Ritux topping the list, and then we have abatacept, which is no longer available to us in the country, was available, but was withdrawn for commercial reasons, not scientific reasons. And then we have tocilizumab, which is available. Now, this is a controversial area, but I thought let me catch the bull by the horn. Dosing of glucocorticoids in CTD ILDs. And this is where A does not equal B and B does not equal C. In the context of scleroderma, the use of corticosteroids is minimal, but this is what Sapan will talk about. But the ILD in the setting of rheumatoid arthritis, active ILD, and if you have decided to treat, you need modest doses of steroids. And in terms of prednisolone, 0.5 milligram per kg. So start with 20 or 30 milligram. Mega dosages are not required. And this is in contradistinction to inflammatory myositis, where in the setting of antisynthetase syndrome, active muscle disease, the steroid doses may be 1 milligram per kg, 40 to 60 milligrams per day. So the ILD of CTDs is not treated identically. Scleroderma, be very cautious with steroids. Rheumatoid arthritis, your starting dose is more modest as compared to the IIMs. And this is an algorithm which I have put up. If you have polysymptomatic patients, you need to observe them. If you have symptomatic patients, then you categorize them into those with severe articular disease or mild articular disease. Where joints are active, the lungs are active, Ritux may be a good choice in addition to steroids. Where the joints are not so active, then corticosteroids with mycophenolate, and this is based on the premise that mycophenolate is good for the lungs but is virtually indifferent to the joints. So if you have a person who's very much symptomatic in terms of joint disease, mycophenolate is not going to help the lungs but is not going to help the joints, and which is why Ritux is preferred in this setting. Or you need to combine it with other disease-modifying drugs like hydroxychloroquine or leflunomide. If you have rapidly progressive ILDs, you take recourse to cyclophosphamide, methylprednisolone pulses, and then, of course, the refractory disease, unresponsive, consider lung transplantation. What about progressive fibrosing ILD? Not all patients will respond. Some people would have fibrosis, damage more than activity, and this is where you talk about nintedanib, pirfenidone, lung transplant. In general, there are no guidelines, but they are added to corticosteroids and the disease-modifying drugs and immunosuppressants. So you add them to mycophenolate, to glucocorticoids. If you find that it is more end stage and less likelihood of reversibility, you withdraw these steroids and MMF and you offer people nintedanib, and this you do need help from pulmonology colleagues also. Friends, I would like to end my formal presentation by mentioning that ILD is an important extra-articular complication of rheumatoid. You need to identify which patients need treatment. Glucocorticoids with mycophenolate, mofetil, or rituximab are widely used. Other agents include azathioprine, cyclophosphamide. In the context of pregnancy, azathioprine is pregnancy compatible. Head-to-head trials, long-term studies, in this subset of patients, they are not widely available. Much of the literature comes from systemic sclerosis. Nintedanib is used for fibrosing ILD. And if this has stimulated your interest, this is a review article that I co-authored with Sakir Ahmed, one of the brilliant young rheumatologists now in Odisha, alumnus of SGPGI, management of CTD ILD, published recently in Current Pulmonology Reports. And for physicians who are interested in rheumatology, this is a labor of love. Nothing theoretical about it, only clinical stuff, clinical rheumatology. Thank you very much for your kind attention.
Thank you, sir. Excellent talk, and you covered each and everything about rheumatoid ILD. And this talk was practical: how to diagnose, when to suspect, how to diagnose, and how to treat rheumatoid lung disease. We will take all the questions after second lecture. Second talk is from Dr. Sapan Pandya. Dr. Sapan is rheumatologist at Vedanta Institute of Medical Sciences and Assistant Professor, Department of Rheumatology and Medicine, Srimati NHL Medical College and SVP Hospital, Ahmedabad. He is my colleague, DM from SGPGI Lucknow in clinical immunology and rheumatology. He is past secretary of Indian Rheumatology Association. His major publication is methotrexate twice versus once weekly in rheumatoid arthritis in Rheumatology International. Then combination of methotrexate and hydroxychloroquine in chikungunya arthritis that was published in Indian Journal of Rheumatology 2009. And his primary focus is primary Sjogren's and palindromic rheumatism. Now I request Dr. Sapan to deliver his talk.
Thank you, Banwari boss. Good morning, everyone. At the outset, I'd like to thank. Can I start the share screen so that we save that much time? Yeah. Can you see the?
Yes, Sapan.
Okay. Thank you. So thank you, Banwari boss and Niramaya Foundation for this chance to talk. I must confess that I have not been a regular attender of these talks that Banwari has been doing for the last some time, and after listening to Dr. Handa today, I felt that it really must be worth listening to these talks, and so I shall try and do them from now on. And what I have done in the next, what I'm going to do in the next 20-25 minutes is to try and recapitulate what evidence we have for scleroderma management. As I understand, most of the audience is going to be fellows of rheumatology and all postgraduates of medicine, and so I'm sure that this is not new for them. Most of this is already known, but since it is students, we have to share what is evidence-based rather than what is eminence-based, and I'll try and pitch in what is my little experience with the use of scleroderma. So having said that, let me go to the first slide. This was something that I read in the rheumatology, in the journal, the Rheumatologist, and was a write-up about 2019, where it said the patients will often benefit from an uncertain physician, particularly one who is aware of their uncertainties. So I think it is okay not to be certain about few things. In fact, those of you who are from SDPGI will realize, and there was this joke at SDPGI, that if you end your seminar by saying that this is the for evidence and this is the against evidence, and that we are still not sure and we need more evidence, then you actually get more marks for the seminar than if you are very certain. So I think, and I understand now why that is so. This is going to be my outline of the talk. As Dr. Handa did, I also come out with the case vignettes, but contrary to what he has put, these are not cases that I have seen. These are case vignettes from a publication by Dr. Dinesh Khanna recently, in about 2-3 months back, where he has come out with those very useful vignettes which we say day to day. So I'll just take those up. For those who have read, it will be a revision, and then issues in management and what is the baseline assessment in these, what are the predictors, and I'll go back to the cases when I do that. What is the baseline treatment decision based on what information we have at baseline, and then coming to follow-up, what are the issues with monitoring therapy, and what about the refractory cases who don't respond to any, and what is the evidence therein for each of these. I'll be just quoting the main studies. All of you know that there are ample studies in each of these, but I'm sure you've gone through most of those. What are the other agents that are used? And a penultimate slide on the differentials, which much of this Dr. Handa has already said, so might be a repetition of things, how to prognosticate these patients, and the key takeaways at the end. So this is the first case vignette that Professor Khanna has mentioned. This is a 50-year-old gentleman with a new diagnosis of diffuse cutaneous scleroderma. He has 2 years of illness of puffy fingers. He still doesn't have any dyspnea. The MRSS score is moderate to high. He has an anti-TPO which is positive and a CRP which is rising, but the lung function is still okay. The HRCT also shows minimal lung involvement. So clearly this is all of us who deal with scleroderma, and probably this might be useful for the first years of fellows of rheumatology, is that this is a time period when actually the lungs started getting involved along with the skin in diffuse scleroderma. In the first 2-3 years, we all know that the ILD mostly happens in the first 3 years to 5 years. Not that there are not late progressors, but usually. And therefore, this is the time when we have to act, and people have tried to treat with various kind of immunomodulators in this therapy. So this is a case of, if I go to the next slide, just try and remember these cases, we'll be coming back to them. So the first case, if I can go back, is a case of early disease, but with markers and predictors which suggest that this patient might have severe ILD later on, or is likely to get into interstitial lung disease. The second case, again from the same manuscript, is a 20-year-old lady, comes with limited cutaneous scleroma. She has sclerotic activity for the last 3 years. There's dyspnea on exertion for the last 6 months. You find crepitations, oscillation. The Rodnan score is okay, so it doesn't have much of skin involvement actually, but there are telangiectasias on the face and hands, but no signs of right ventricular failure. She's anti-centromere antibody positive, and there is some data to show that this might actually be protective for ILD. She also has moderate ILD in terms of the FVC and the DLCO. The TLC is maintained, and the HRCT confirms the non-specific interstitial pneumonitis. This is just to remind you of the last NEJM last Thursday, when there is this photograph of a tongue telangiectasia, and I'm sure we also have, most of us, especially seniors, have imaged both palatal and tongue telangiectasias. So this is clearly a lady with whose ILD has started for the last 6 months, but otherwise doesn't have very bad prognostic markers for the ILD. The third case that he highlights is a 50-year-old lady with rapidly progressive diffuse scleroderma over 2 years. The antibodies are negative. The MRSS score has increased during that period. She has acute phase reactants which are raised, and this also fulfills the criteria for a rapid progress, in the sense that the lung function has deteriorated over the last 2 years, and this is despite full doses of mycophenolate mofetil. The HRCT also shows more than 20%, as Sir pointed out, which is and this is a CT scan picture from this particular publication where you can see that the patient progresses. Not the same patient, but I just put it here, and you can see A, B, C, it progresses. In C, you can see more cysts and some bronchiectasis, traction bronchiectasis, some ground glasses too. So this is clearly a case of rapidly progressing ILD. So case number 1, you had somebody who had bad markers, was early in disease, was a male. Male is also risk factor, is also predictor for ILD, but had no dyspnea to begin with. The second case was starting of ILD in a lady for 6 months, confirmed on CT scan, but the markers are not bad. And the third is a rapidly progressing ILD. Just remember these cases. And the fourth was a case where this lady is a 60-year-old lady with diffuse cutaneous scleroderma since 15 years. No antibodies. The HRCT shows non-specific interstitial pneumonitis. She has had a stable ILD for the last 10 years. She did take oral cyclosporine for first year of disease. After that was lost to follow-up. Over the last 6 months has increasing dyspnea and cough, and when the skin score is sort of stabilized or has actually gone back to almost normal. She has telangiectasias and started having some elements of failure. But the important thing to note here is that the DLC is much worse than the FVC. So the DLC is disproportionate to the lung function restriction which is coming out here. This is just a CT scan showing that for example, a stable ILD for quite some time, and over the last CT scan you can see some progression. So this is a case of a disproportionate DLC out of FVC over the last 6 months, some ILD increase in a case which is stable over years. There can be late progressors, remember, but we have to remember the differentials that come with scleroderma. So what are the issues in management? At baseline, diagnosing ILD, ruling out other differentials, assessing severity and predicting the course. What are the treatment decisions we need to make? What is the evidence available? And then if the patient is on follow-up, how do you monitor the response to therapy? Because you always have symptoms, but there can be subjective differences. So how to objectively monitor those? How frequently to monitor those? And when and how to change therapy? Are there any missing links? Are we missing something? Is something that we're always concerned. This is just to remind you of the course of scleroderma over years. You can see there's such a famous slide that I've not given the reference here, but this is from the Rheumatic Disease Clinic back in 2003. And you can see that this is the period, if you can see my pointer, in the first 2 or 3 years where in diffuse scleroderma you start getting skin involvement. And this is the time we believe that you also start getting the other complications like interstitial lung disease in these patients. And then over a period of time, of course, they start going down. This is the limited cutis sclerotoma graph. We know that there are overlaps between these two also now. This was a very good line from the same manuscript by Professor Khanna, where he has stated that there are no standardized definitions of clinical ILD at this point of time. It may be conceptualized as a disease state that affects how a patient feels, functions, or survives in the setting of mild to severe extent of ILD on HRCT. These patients have symptomatic sclerotoma ILD, example cough or dyspnea attributed to Galli, or impact on day-to-day functioning, although significant arthritis and other disease features may preclude exertion, making this a challenging disease feature to reliably identify. This sentence more or less summarizes all the issues that we have with sclerotoma, and therefore I put it here. Coming to the baseline assessment, a PFT would be needed, although we know that the sensitivity and specificity of in early and mild cases is not very high. You may miss up to 60% if you solely rely on PFT. There are studies which have shown this. The DLCO decrease is earliest to occur, but may be normal. The decrease on the DLCO is usually proportional to the lung volumes, but sometimes if there are other causes, and we'll be coming to that when we discuss the fourth case, then the DLCO goes down, worsens. The 6-minute walk test, the problem with that is Raynaud's and putting in the looking at the saturation, and therefore earlobes clips might be better, but I have never used it, nor have I seen anybody using that. There is some data to show that nail-fold capilloscopy, which I think Dr. Hunt also mentioned, may correlate with heart and lung involvement, independent of the antibody assays that they have. Coming to the lung biopsy, which sir also said is usually not needed, and I put this here just to remind myself of lung biopsy is usually not needed unless you are suspecting a malignancy, or you want to rule out an infection by culturing that tissue, or very rarely when you want to change treatment that is very aggressive disease. Otherwise, usually it is not needed. This is a image of, on the left side, the first 4 are NSIP. This is, of course, the pulmonary vasculature showing thickening of the wall. And this on the right side is the UIP, which shows fibroblastic foci. If you can see here, this is a fibroblastic focus. It looks like a dome. This is some material inside, and usually these are peripherally, there is centrilobular sparing here, and there are more peripheral lesions in UIP. Coming to the baseline assessment, again, the chest X-ray more or less now, I don't think many people use it, and this is replaced by HRCT, although in our country it would still be useful as a screening assay, especially in rural areas. The HRCT, all patients should undergo, that is what the recommendations are, both in supine and prone. The earliest change may be a subpleural crescent posterior part of the lower lobe. And if you see centrilobular opacities, you have to think of aspiration pneumonia. The extent of involvement predicts mortality, but the important thing is that more than the baseline HRCT severity, it is a progression of severity over time, or a progression or extent of HRCT increasing over time, which is of more value. And even then, more than this, the worsening on PFT is actually of more value in assessing progression in sclerotoma ILD. Dr. Handa talked about the GO criteria. This is one way of looking at it, that if there is less than 5% and no evidence of disease progression, you might just watch. If you have more than 10% FVC decline, then of course it's a progressor. But in between, you have to look at the DLC, and if there is more than 15%, then that again is a progressor. These are some of the markers. There is so much of data, and there are such long tables on this, but this I thought was a good summary. We use CRP, and we know from the tocilizumab study that CRP is important in these patients to do. CCL18 seems to be a reliable marker, and there is much talk about this in ILD. The other markers, of course, have been there since quite some time, but have not seen the have not seen the light of the day. And then you have the antitoperins. There are some other antibodies also, like RNA polymerase 3, which are found to be, and these are some other antibodies. We know that there is ethnicity, vulnerability, advanced age, male sex, and some have identified, have actually mentioned how much of efficacy, say less than 65%, DLCO less than 55% would be significant at baseline, and the extent of ILD on HRCT more than 20%, as Professor Honda pointed out. So these are the predictors of progressors in ILD. Coming to the baseline treatment part, and I hope I'm on time. Yes, I am. So this is again the algorithm from the same manuscript, and it gives us a good summary of what is to be done. So you first gauge the disease severity based on if the patient has symptoms, what does the pulmonary function show. And if there are no symptoms and there seems to be low risk of progressive ILD in terms of normal pulmonary function and all, then you can just monitor the disease in these patients, which means look at them every 3 months clinically, and every 4 to 6 months you do a PFT. For the first 5 years, usually after the first 5 years, these patients don't get ILD. An HRCT, a baseline, of course you do, but then you repeat the HRCT only if there are symptoms or there are PFT abnormalities show worsening or there is declining in the 6-minute halt test. In that case, you consider formulary treatment. Otherwise, you can just observe these patients. I have not included corticosteroids in my discussion at all because low-dose corticosteroid is something that we use in scleroderma for other things like joint pains, and which is fine. And these patients are on steroids for some time. But otherwise, there is no role of steroids. High-dose steroids, in fact, lead to the renal crisis, and therefore they are not used. Coming to and if there are markers of high progression, such as the first case that we discussed, in that case, you of course start therapy. What therapy will come into that. And if there is established clinical ILD already in these patients by doing an HRCT or the pulmonary function showing that, then again you look at if there is just predominantly lung involvement or there are other like joints and other systems involved. Based on that, you can decide the therapy, or if there is other organ involvement, then based on that. Now let's first see the first. Of course, this is disease monitoring where there is low risk at all. You just monitor. But let's come to this part where you have early markers. And if you recall the first case, this patient had with markers suggestive of involvement, but no symptom then, and very little involvement. So this was clearly a patient who was at risk. Let's see how to treat this. And if you see the treatment part, tocilizumab and mycophenolate mofetil, let's look at the evidence. So coming to tocilizumab, these are the landmark trials which have led to the approval of tocilizumab for scleroderma ILD early in disease, and especially in diffuse scleroderma. The FASCINATE was a study which was actually, these were for the skin improvement, and the primary objective was actually not met with in terms of MRSS scoring. But when they looked at the PFTs of these patients and the FVC, they saw that patients on tocilizumab did better than those patients who were in placebo. And therefore, and that led to the FOCUS study, the other one, which was over 48 weeks. There was an open label extension of the first one also. And the difference was about 241 ml, which is quite high between the placebo and the tocilizumab in terms of the FVC reduction and decline. And these patients continue to benefit. The important thing to note was that from mild to severe cases, all of them benefited. So even severe cases, tocilizumab did seem to benefit. And this is the graphical presentation, whereas the MRSS score was not met with the primary objective. They saw that the FVC decline was reduced in those on tocilizumab. The second drug, if you remember, the algorithm was MMF. What is the evidence there? It's from the SLS2 study, scleroderma lung study 2, and I'm sure that all the residents and the fellows have been asked this question on rounds. What was the study about? Was mycophenolate up to 3 grams versus cyclophosphamide, and what they saw was that while there was not much of a significant difference in terms of statistics in both of these, since mycophenolate is a safer drug and the time to withdrawal and tolerability was better with MMF than with cyclophosphamide, and this was one study which has virtually established MMF as the first line therapy not only for scleroderma ILD but also from scleroderma, taking from scleroderma to other diseases, as Professor Hunt also mentioned. The problem with MMF, of course, is dosing, and that it has to be avoided with antacids and other things. But if there is a problem, Professor Khanna advises taking it with food and or using the mycophenolic acid, the sodium salt, which is you have to dose it 760 milligram 3 times a day if you want the equivalent. And the important thing is to give up to 3 grams. In the SLS2 study, they titrated it up in 3 to 4 months over that dose. Our patients don't seem to tolerate these very well, also plus the cost problem. You have to modify in the end-stage renal disease, avoid pregnancy and breastfeeding. PCP prophylaxis is not needed in MMF. There is still not enough evidence to suggest that. So these two are the drugs which could be used in the first case scenario. Now let's look at the second case scenario where the patient has an established ILD. but doesn't seem to have other organ involvement except for the lung. And here they recommend giving nintedanib as antifibrotic, or if you must give immunomodulatory, then mycophenolate and cyclophosphamide. So we look at the data with nintedanib and cyclophosphamide. And if you remember, the second case was doesn't have NSIP is established, doesn't have much skin score, and there is no arthritis or any scleroderma evidence of scleroderma disease anywhere else. So nintedanib, coming to nintedanib, what is the evidence? This is the Census trial, from which it led to the approval of nintedanib in scleroderma ILD, so half of these patients were on nintedanib versus the other half on placebo, and the difference between the two arms was about 40 ml, which came out to be significant. Another study involved again more than 500 patients, but scleroderma was only a small part. This had all kinds of connected issues with ILD and also rheumatoid arthritis. The reduction in decline of FVC was seen first 1 or 2 years in patients who don't respond to cyclophosphamide MMF or don't tolerate these. Those are the ones where you should be using nintedanib. We are not sure whether we should give upfront combination therapy to these patients, or if monotherapy works. There is still not enough data. The problem with nintedanib, and I have used this I must admit, in only about 4 or 5 patients, and as Professor Handa said, usually with the usage of these drugs, we do involve the pulmonologist simply because they have more experience. But the problem is diarrhea, and all of you had seen that was also a part of the Census study where about 1 month, in the first 1 month, about 60-70% patients had diarrhea. And so you have to reduce the dose, or you might have to reduce the dose of MMF. The combination, both of them cause diarrhea, so that's a problem. And you might need to reduce both of these doses. Now, whether that affects the outcome, we don't know. Liver, there are liver issues, so you have to monitor the transaminases, and it is to be still avoided in pregnancy. This is just to show that what is important to see here is that nintedanib plus MMF actually did better than placebo plus MMF. So there is definitely that benefit with the addition of nintedanib. But the benefit in IPF was, of course, since they are patients who are very severe, this is just to compare these two. Our patients are generally better than the IPF patients. Coming to cyclophosphamide, is largely borrowed from the SLS scleroderma lung study 1 data, and that established cyclophosphamide as the first line then, but now has become second line of the SLS2 study. Was seen in FVC, TLC, cough, and radiography, all of these parameters. The important thing to note was the more severe patients responded better. Now, both of these two studies used oral cyclophosphamide. But the benefit here, they stopped cyclophosphamide 1 year, was not sustained after stopping cyclophosphamide. So when they evaluated these patients at the second year, the benefit which was obtained in the first 1 year was gone. And other studies have also shown plus and minus improvement with the use of cyclophosphamide. There are also studies with intravenous cyclophosphamide. Most of us would use IV cyclophosphamide rather than oral for obvious reasons. So it is a second line agent, and intravenous route is preferred. These patients do need PCP prophylaxis. This is to show the SLS1 study where cyclophosphamide did better than placebo. And so coming back to the last case, to the second last case, where this was a rapid progressor, multi-organ, and also had a multi-organ involvement. In that you use rituximab, or is the other drug which comes out here apart from the previous drugs. So we remember that this was a rapid progressor over 2 years, FVC decline. And so you could use MMF cyclophosphamide in these patients, but the other drug to use is rituximab, especially if you have joint involvement and other problems. And in an open label study, while there is no large amount of patients not been recruited, this data showed that improvement in FVC was seen in rituximab and not cyclophosphamide. This was a study which compared these two. Another observational study of refractory scleroderma, these patients had been on MMF, but they did not respond. And after rituximab, they did respond after 1 year. So, and very importantly, in a network meta-analysis with multiple comparison study, which has been referenced here, actually rituximab came out to be the only study which showed a reduction in decline in FVC. There is a trial data which is still awaited, but in this study they actually included all the studies, and rituximab is the only one which came out to be significant in terms of reduction in decline. So it seems to be a good drug. We need more data. At this point, I'd like to quote both Professor Alkendu's study from Kolkata, where they did use rituximab, and they have shown up to 60 to 67% FVC rise from the baseline in rituximab patients. And they recommended as an option to cyclophosphamide. In their study, it was actually significantly more than cyclophosphamide. And also mentioned Padmanabhan Shenoy's study of MMF, which had about 57 patients, and where again MMF and cyclophosphamide were equal. So we have Indian data to validate both of these as well. On follow-up, what to do? So in mild, low probability of progression, you do annual PFTs. In others, you do 3 to 6 months. HRCTs to be repeated only if we discussed this, warrant a change in therapy. The problems with monitoring are that there is very slow improvement in scleroderma. It may be masked by fibrosis, and that our target is often stabilization of PFT rather than improvement. This is to show what honeycombing and UIP looks like. These are the bad cases, or fibrotic NSIP. So this is an algorithm which shows that in patients where you have worsening of symptoms, you also rule out pulmonary arterial hypertension with the DETECT algorithm, and some other differentials which you need to consider. So coming to the, this is to summarize what are the other refractory drugs. You have lung transplant and stem cell transplants. What is the data for that for refractory cases? The SCOT study, scleroderma, cyclophosphamide, other transplant or transplant study showed that the HSCT arm did better than over 5 years almost. And there is also lung transplant data to show that these patients do as good as the other CTDs with ILDs. There is, but worse than IPF and comparable to idiopathic pulmonary hypertension cases. Other agents, I won't go into details. Azathioprine has been tried. We use that sometimes as a maintenance drug where you cannot use MMF and rituximab for some reasons. Pirfenidone is this study which was actually for safety and tolerability in scleroderma ILD, and it did establish safety, but we are still waiting the SLS3 to look at the efficacy data of pirfenidone. Abatacept has had plus and minus studies, but mostly a randomized study did not show improvement. And important not to forget is supportive care like oxygen therapy, vaccines, and asking them to lie down 2 hours after taking meals and those things. This is another study from Kolkata where they used pulse cyclophosphamide and maintained with azathioprine. The last study you saw that the DLC was disproportionate to the FVC in these patients, and therefore these are the differences that you need to rule out. If it is out of proportion, lead to pulmonary hypertension, pulmonary capillary hemangiotosis, veno-occlusive disease, heart failure, drugs. Sir talked about that, aspiration, infections. What is the prognosis of scleroderma ILD? So 9-year survival ranges, and there is organ involvement is 72%, when no organ is 30%, but when there is no organ involvement is 72%. And this is, most of the patients have mild decline. A third of patients are stable, and over 8% rapidly progress. Those with combined emphysema and fibrosis have worse prognosis. This is to show that if you have combined PH and ILD, you do the worst, followed by PH, followed by ILD, and then this is when there is no involvement. So the takeaways are what are the issues mathematically? When does the patient come to you? So the patient comes to you early. There are markers of high CRP and suggestive of like anti-TPO positive, mild ILD starting in these patients. Put them on MMF or cyclophosphamide or tocilizumab if they can afford. What is the baseline assessment? HRCTs in all, PFTs, maybe an echo to rule out PAH at a 6-minute walk test. How does he or she progress? Every 3 months to 6 months PFT. In those where it is likely, in stable case, you may do it annually. And what agents to use? We discussed the various. There are issues with trials which I'm not going into. Most of them are small samples studies. There are a lot of observational stuff, very rare randomized studies. The ones we discussed are the only randomized control studies. And there are issues with the variability of usage of pulmonary function and DLCO. And then there are India-specific issues which I have not discussed because that would not be covered in this half an hour. Cost effectiveness, compliance, outcome measures. There is data to show that only 50% of rheumatologists actually order CT scans, and which is true, we all know. So with that, I think regarding scleroderma, I would like to end on optimistic note that one should be able to see that things are hopeless and yet be determined to make them otherwise. Thank you, ladies and gentlemen, for the attention.
Thank you, Saban, for excellent talk on ILD issues in systemic sclerosis. And now I will request both Professor Rohini Handa sir and Saban to discuss some interesting cases. I received yesterday from my colleagues the real life situation cases, and I want to share. This is the first case. 37-year-old female. She's a doctor. She presented with insidious onset progressive dyspnea on exertion with occasional dry cough for 2 to 3 months. A known case of hypothyroidism, allergic rhinitis, and chronic urinary tract infection since November 2020. And she was on nitrofurantoin 100 mg daily since then, last 1.5 years. No extra pulmonary features. Her routine investigations were normal, RF and DCCP normal, PFT normal. 2 abnormalities she had, HRCT chest, NSIP pattern ILD with mosaic attenuations, ANA 3+ mitochondrial pattern, 1:80 titer. There are 2 issues in this case. One is how to approach, and second is it nitrofurantoin hypersensitivity or interstitial pneumonia with autoimmune features? Yes, sir.
I think this is a typical clinical situation that you encounter. The issue here is that is it the drug or is it something which has come up de novo? And almost any drug can cause all these issues. So idea is withdraw the drug. Whatever resolves on drug withdrawal is drug induced and whatever stays is unlikely. The other method is to get ENAs done. And if on ENAs you find multiple autoantibodies, then the chances of a CTD-ILD are higher. With one single isolated ANA, 1 in 80, you cannot, she's 37, 5% of young people may have low titer ANAs. But if your immunoblot or the ENAs show multiple antibodies being present, that is less likely to be stochastic or by random, and I would pay heed to that. Stop the drug, order an ENA, look at the ENAs, multiple autoantibodies present, less likely to be by chance. Single isolated ANA, you cannot say. A single swallow does not make summer.
Thank you, sir. The second case is 45-year-old male with cough, progressive dyspnea, and often on Arcellias for 6 months. He denied any extra pulmonary features, no synovitis, although he gave history of Arcellias, but no synovitis. Acute phase reactants slightly raised, rheumatoid factor slightly high, NSIP pattern on HRCT, PFT normal. Again, this patient was referred from chest physician for the evaluation of CTD associated ILD. What autoantibodies should be ordered for evaluation as first line and then subsequently? This is Dr. Sapan.
Yes, thank you, Manwari, for the question. I think if you look at the definition of IPAF, you have almost all antibodies except for ANCAs. For some reason, ANCA has not been included in the IPAF chart. So apart from that, ideally, you should do all the antibodies. But having said that, in India, because of cost constraints and other reasons, I would do the basic tests like anti-CCP and because palindromic rheumatism, which comes with arthralgias, ANAs, maybe a profile ANA. And if there is some evidence of myositis, like sometimes you have these mechanics hands or some heliotrope, which you can, or some Gautrans, which you can pick up rarely with experience, then maybe an myositis antibody profile also. But otherwise, I would, except for MSAs, I would do the rest of these patients and then try and look at if any of them are positive.
And if you get cytoplasmic ANA or nuclear ANA pattern,
so cytoplasmic ANAs are usually reported with anti-ribosomal P, we know, and liver specific antibodies, and anti-Ro can be cytoplasmic. So even if it's just an immunofluorescence strongly positive with an interstitial lung disease pattern, we take it as IPAF. ANA positivity alone without ANA profile positivity is also included in IPAP. So if it's significantly positive, because there are those B cell clones which are producing those antibodies. So,
and I think if cytoplasmic ANA positivity is there, then we can go for myositis specific autoantibody.
Yeah, anti-Jo1 is, yeah, that's also true. Yeah,
because anti-MDA5 and that can also be positive in this.
Yeah, MDA5.
Yeah. The third question is 55-year-old male presented with fever, dry cough, and dyspnea on exertion since November 2020. Again, he's a doctor. Hospitalized, diagnosed atypical pneumonia on HRCT, RT-PCR for COVID negative, thrice, treated for COVID pneumonia, improved. He had recurrence of symptoms, both dyspnea on exertion and cough in May 2021. And that time he also had myalgias, proximal group of muscles. His CRP was high, FVC 68%, diffusion capacity 39%, HRCT showed UIP pattern, ANA 1:160, homogeneous pattern, and his myositis specific autoantibody or PL7 was positive. And again, he also had P-ANCA and high titers MPO positivity. So there are three issues. Dr. Handa, sir?
I think in this,
yeah,
I would not ignore a MPO more than 100. And we reported our experience with microscopic polyangiitis more than 20 years ago. And ILD could be a part and parcel of that. I would be extremely reluctant to ignore this. Without CPKs, with only PL7, without inflammatory muscle disease, on the contrary, I would be very reluctant to call it anti-synthetase syndrome. The evidence that has been offered to me is rather sketchy. All I am getting is one PL7. I do not know the CPKs. I do not know the muscle enzymes. I do not know the muscle strength. I do not know whether there were mechanic hands. But I would not ignore MPO ELISAs more than 100. PL7 I would take in the context of muscle weakness, inflammation, EMG, or a muscle biopsy. Well, ANAs are usually all over the place. And anti-synthetase syndrome, or for that matter, microscopic polyangiitis, doesn't exempt you from getting COVID. And you could then have post-COVID fibrosis on top of an autoimmune disease. There could be both things going together. One does not exclude the other. And if MPO is positive consistently and persistently, I would treat it with corticosteroids and mycophenolate mofetil. I would try to look at the urine very carefully. Microscopic polyangiitis could be associated with kidney involvement. And I would want a good nerve conduction to pick up subclinical neuropathy, which would be unusual in a muscle disease, but would be not uncommon in a vasculitis. So whether we are dealing with a vasculitis or a muscle disease, I mean, without CPKs, without EMGs, NCBs, but this is my take on the data set provided.
Sir, his muscle enzymes were normal, EMG was normal, his MRI, MRI of both the hip joints looking for the thigh muscle inflammation was perfectly normal. And he had basically normal renal function test.
Okay. And nerve conduction?
No, not done.
Okay. I would do that and I would treat it with corticosteroids and mycophenolate mofetil.
Sir, he received this high doses of steroids and mycophenolate mofetil for 4 months, showed good response. And while tapering steroids, he had recurrence of disease.
Okay, then in that situation, I would try to use Retux, whether it is a vasculitis or it is a myositis related ILD, there is enough. And the fact that he improved, post-COVID fibrosis doesn't behave like this. I mean, the insult is over and you don't deteriorate. So if you improve, and I mean deteriorate in the sense that if you improve, but this kind of a waxing waning course suggests immunoinflammation. I would not worry too much about the label, but I would go all out to treat and Retux him.
Perfect, sir. The next patient is 65-year-old female doctor. She has inflammatory polyarthritis, RA distribution since January 2020. She had high ESR, high CRP, and both rheumatoid factor and anti-CCP positivity. Treated with methylprednisolone, that is dipomedrol, weekly for 4 weeks, and methotrexate 15 milligram per week. After 6 weeks, presented with dry cough and dyspnea on exertion. HRCT chest suggestive of ground glass appearance, mid and lower zones, and her oxygen saturation reduced to 90%, PFT was normal. So this patient, her first question was, is it methotrexate pneumonitis or rheumatoid ILD? Professor Henderson.
Well, I would look at the eosinophil counts. And if you want to get to the bottom of this problem, because she has just started with methotrexate and she would clearly have concerns, there is one which is the path of least resistance. Withdraw methotrexate, switch over to leflunomide, hydroxychloroquine, and see how it pans out. And otherwise, the scientific answer is she needs a tissue diagnosis. She needs, and much will depend, the same people who would insist on an answer expecting the rheumatologist to be the know-all, the moment they are offered a biopsy, with due apologies, would step back. So इसका बड़ा simple है, ये तो रोज clinical practice में leflunomide, hydroxychloroquine, steroid, let it settle down. जो ठीक हो गया methotrexate, hypersensitivity, जो बच गया वो RA-ILD. नहीं तो tissue diagnosis.
Saban, what is your comment on this?
I think perfect. Very well said, sir. And that's what we do. I think we overdiagnose methotrexate pneumonitis, and these patients may be having ILD at baseline, which somehow we have missed or somebody else. That's why it's very important to look at these cases at baseline itself. And if it's a doctor, I would just withdraw, as sir says, absolutely.
Then one question.
Biopsy would be, but what I find is the same doctor who wants you in the first breath to give an opinion, the moment you talk about biopsy, steps back.
Yeah. A question from Dr. Hari Krishnan. Personal experience of JAK inhibitors in rheumatoid ILD when joints and lung have active disease and affordability issues to rituximab.
Well, actually, Abra has also put this question up about JAK inhibitors, Abra Chaudhary from Calcutta and Hari Krishnan. And actually, JAK inhibitors, there are no long-term data trials to inform you of the decision. That JAK inhibitors as a first-line therapy for ILD, no. There is some data that is beginning to emerge. JAK inhibitors are the flavor of the season for all immunoinflammatory diseases, whether of the skin or of the gut or of the joints. So intuitively people are kind of thinking it might help, but data-driven approach or data to inform decision, not available. Some prelim reports, anecdotal case reports, those kind of data is available. I would not use it as the primary based upon the current state of knowledge.
Saban, what is your experience?
No, I think sir has perfectly said it. And the only thing is that there is some data in myositis where in the anti-MDA5, when they used tofacitinib early on, they were able to sort of abort the interstitial lung disease in these patients. So that is the only thing that we have. And as sir said, most of these patients don't, and we have, all of us have faced this, right? There is mild ILD, joints बहुत ज़्यादा है, तो we use tofacitinib and we monitor the ILD. Mild ILD का कोई issue नहीं है. लेकिन अगर बहुत if it's a quickly progressing UIP, then I wouldn't risk something which is not being tried, as sir said.
And sir has already explained that severe ILD, severe progressive ILD is not very, very common. First, we have to look for the severity of the ILD. The next question is from Dr. E.S. Bakuni. Any difference between subcutaneous and IV tocilizumab?
I don't think I should be answering somebody who's my senior, but anyway, since I've read up, they've used subcutaneous tocilizumab in the study. So that's the data we have. I don't see a difference between IV and subcut, so it's a matter of choice. You may use IV as well, but the data is on subcut 162 milligram weekly.
162 milligram weekly?
Yeah, that's right.
Yeah, in focus trial.
Yeah, that's right.
That is for early PSS. Very early.
Yeah.
Sir, any experience of yours for subcutaneous versus IV?
I think both work equally well. I am not aware that you see one does not work or the other works better. I think both work.
Okay. Then next question
Maybe I would like to know from Sapan, is there any difference, Sapan?
No, I haven't used much. I haven't used tocilizumab in any of my patients with scleroderma ILD as of now, in scleroderma ILD. So, but in Still's disease, I have seen that sometimes intravenous works quickly and better instead of subcut because of the nature of the disease, which is high. So there I have preferred to use intravenous in the. But otherwise, even COVID when we used, and Dr. Atul Patel, my ID companion, actually builds the use of subcut toci in these patients. So I think they are the same otherwise.
And in Stills, what dose of tocilizumab you used?
Well, you can go up to third. You can go up to
12 milligram per gram.
Yeah, that's right. Yeah.
The next question is from Dr. Prashant Chotalia. Regime of IV cyclophosphamide for CTD-ILD.
I think this is the same regime. There's nothing, people haven't tried different regimes. The classical NIH regime, 15 milligram per kilogram body weight monthly. You give IV infusion, hydrate the patient well. You may or may not use Mesna. Mesna is more defensive practice than anything. But 15 milligram monthly for 6 months, that's the standard protocol, which at least I follow and which has been followed widely.
That's right. 750 milligram per meter square. Yeah.
There are few reports of that Euro lupus protocol also fortnightly. But as Dr. Handa has said, that most widely used is that NIH protocol.
See, the problem with Euro lupus is that you need to get the patient in every 15 days.
Yeah.
And in a private hospital setting, with the cost, every time you pay for assistant charge, this charge, that charge, if it becomes patient has to come in, maybe it depends upon the work setting also for an individual. Otherwise, every hospitalization costs money for the patient.
Next question from Dr. Vikas Sharma. A patient of MDA5 ILD who responded on combination of TEC and cyclophosphamide, what should be regimen for maintenance therapy, either tofacitinib or tacrolimus alone?
There can be no one right answer to this question. I mean, this question is the person on ground will take the decision. I would use any day tofacitinib because I'm more comfortable as a rheumatologist. Tacrolimus I haven't used much. But there will never, it depends upon patient tolerability, what you encountered in this journey to getting him into remission. You won't get straight cut and dried answers. It's not black or white. There are shades of gray. I mean, this is something which you on the ground have to improvise. Nobody can say that this is the method and nothing else. No, not at all.
Yeah, people can use even azathioprine also or for maintenance. Yeah.
Azathioprine is a very good drug where pregnancy, breastfeeding are contemplated. We used it for lots of time. A reasonably safe drug to handle. And I mean, azathioprine now has been replaced by mycophenolate mofetil. But GI tolerance issues can be more with MMF than they ever with azathioprine.
So, Sapan, you have given two clear messages. One is no steroids in systemic sclerosis ILD management. And second is HRCT, baseline HRCT in all these patients. Is it clear?
Yeah, these are the messages. But then, how much of that we follow, it's difficult in our country to do HRCT in every case. So, but ideally, yes. And steroids will have low dose for arthritis and other things, but not for ILD.
And Dr. Handa's message is use that 0.5 milligram per kilogram per day steroids when needed in rheumatoid ILD. Prevalence of rheumatoid ILD is very vast, very high, but severity of ILD varies and it is less common. Next question is Dr. Swapndeep Singh. Would you start methotrexate in a patient who has been diagnosed with RA and ILD and is treatment naive? And at what dose?
Answer is straight. This is what I mentioned. Methotrexate has got nothing to do with ILD. You will use it in 15 mg the way you started with other patients. Yes, you would not deny this patient methotrexate, and if the ILD requires, you will need corticosteroids. So this is exactly the message that we are trying to give. And thank you for posing this question so that we can iterate what we said. Yes, you can use methotrexate in this and the same dosage as you would use in other patients. You treat them no differently in terms of dosing.
Sir, the next question is from Dr. Sumit Singla. Do we treat UIP-ILD, and if so, how aggressively? Sapan.
Well, it depends. Yeah.
And sir can answer.
Sir, you go ahead, sir.
Sir, you go ahead, please.
No, I mean, much depends upon, I'm a clinician. Irrespective, and I repeat, irrespective of the HRCT pattern, if my patient is symptomatic and if the PFTs are showing a decline, I would not deny treatment just because the radiologist has reported UIP pattern. By and large, NSIPs are more responsive. It does not mean that UIPs will not respond whatsoever. UIPs in the context of rheumatoid arthritis, if they are symptomatic with physiological abnormalities, I would treat. But at the same time, I would be circumspect. I would review my patient frequently. If I am meeting my treatment goal, I would continue, de-escalate down the line and maintain. And this is a commonsensical clinical principle. To deny a patient treatment based upon a presumable radiologic type, which is thought to be less amenable to treatment, and when you are looking at it through the eyes of a radiologist, I mean, that goes against the grain of common clinical sense. I mean, I could not be more forceful than this. Sapan, your take.
Well, I agree, sir, perfectly. And what people have seen is that UIP is a bad prognostic marker, and therefore it is likely to progress. It doesn't say you don't treat them. You still treat them, especially if they are early on and you pick up the pattern. But if they are very late in the disease, it's a different thing. If the patient has extensive ILD all over both lung fields and is UIP and is an old patient, 80, 85-year-old, and sort of, there you just tell them that bhaiya inko oxygen do, ghar pe rakho, aaram karo. That is a different take. As sir said, it's very individual. But otherwise, I think balancing cost, side effects, and the benefit, we should not lose hope before losing, the relatives should not lose hope before anything happens. So I think we would, as sir said, we would, especially if it's early on, we would start on treatment in these ways.
I have one message here. No matter what the histological type, no matter what the radiological type, no two patients behave alike. If the patient needs clinical treatment, institute treatment, evaluate the patient, withdraw if it is not working.
Yeah.
But to write off a patient saying that your histological type is not going to be amenable to treatment, I do not think that it always translates into clinical practice that way.
Sir, exactly the same thing. Recently, I have seen one patient, again, doctor diagnosed as systemic sclerosis ILD in 2014. That time her FVC was around 62%. And she came to me in 2022. This time her FVC was 38%. And she did not receive any treatment because most of the places she got the answer that there is no treatment for this. And she herself was doctor, so she might have denied the treatment. But you see the decline in FVC, significant decline in FVC, significant decline in DLCO, and radiologic progression. So this we see commonly in these patients. So with this, I thank all the audience, Professor Rohini Handa sir, Dr. Sapan C. Pandya, for sparing time and delivering excellent talk on the Sunday afternoon. And I'm thankful to all of you for this meeting. Thank you all.